This is lesson 7, and this is going to be a relatively short video because most of what I want you to learn this week you're going to be reading about, and you're going to be able to pick it up from the book and also from any videos that I might have for you. But we're carrying on with central vestibular dysfunction, and we're moving on into some more of the somatosensory things that you're going to see beyond the visual vestibular portion. So again, we're looking at selecting appropriate assessments and interventions for these people. And I know we haven't really talked yet about interventions, and that's somewhat purposeful because I think the bulk of what we need to look at is how do we assess these folks, because once we can figure that out, the interventions are going to follow fairly easily, fairly readily. We're going to know what to do. So as you'll recall, there are these central connections that we have in our vestibular system. And in particular, some of the ones that we're going to be concerned about today are the vestibulospinal and vestibulocaudalic reflex, and some of the things that we're going to be seeing, especially when the cerebellum is impaired. So how do we take a look at cerebellar signs? You might have learned how to do a cerebellar screening previously, but there's some good directions in Chapter 8, and you can also take a look at the videos provided for you by the textbook on cerebellar screening. But finger-to-nose test is, of course, where you have the person touching their nose with their finger and seeing if they can target their nose, eyes open, eyes closed. And then finger, nose, finger to my finger. That's the point-to-point test. And then heel to shin, and I'm not going to be able to demonstrate that in the video because I can't get my legs up to where you can see them on the screen, but that is where you're going to take the heel of one foot and drag it down the shin of the opposite leg. And if you see dysmetria or tremors in the lower extremities with that, then that would be impaired. And then diadochokinesia or dysdiadochokinesia, those rapidly alternating movements, can they do those and keep those in sync? And then you're also going to do arms extended, eyes closed to see if there is a drift or tremor. So if those cerebellar signs show up, then you know that there's something going on in the cerebellum that is impacting the person's balance system as well. So what are some of the things that can happen that can cause a central dysfunction? Concussion. Dizziness is a frequent symptom of concussion, and both the vestibulo-ocular reflex and the balance are impacted as a result. 96% of people diagnosed with concussion have a vestibular component to their injury, and yet it's so ignored in practice. We as therapists need to be more proactive in helping people who have concussions in managing the vestibular component of their dysfunction. And it's also been proven in the literature that vestibular rehabilitation improves symptoms after a concussion. So after the period of rest that a person has after a concussion, we need to be beginning immediately or very soon after that. And outcomes are going to be higher for people to progress and recover from their vestibular component if we target the individual specific deficits. So if we're looking at a student's ability to look at the board in the classroom, or an athlete's ability to do the specific moves that they need to do for their sport. Now, stroke can be an older person, but it doesn't always have to be. In fact, the typical person that has a cerebellar stroke is a 50-year-old male. And they're going to have some different symptoms like we talked about before. They might have moderate nausea but severe imbalance. They're going to have those 3 Ds, quite likely. They might have some other neurological symptoms, and they're going to be very slow to compensate. These are those people with that constant hum of vertigo, I call it. It's constantly there, never gets a whole lot better, but it can get worse with greater amounts of movement. We've talked about vestibular migraines in the past too, but here are a few statistics criteria for you as to how a physician would diagnose vestibular migraines. So if you notice these things, this would be a reason to refer them to a physician who specializes in migraines, going through the person's referring physician in order to do that. So a person would have at least 5 episodes with vestibular symptoms of moderate or severe intensity lasting 5 minutes to 72 hours. So they would have to have episodes of vertiginous symptoms. They would also have to have a current or previous history of migraine, and migraine features during at least 50% of the episodes. So they might have a unilateral headache, which, did you know that that's a hallmark of a migraine, is that they're very oriented. They're oriented toward one side of the brain. Photophobia or phonophobia, so they're light and sound sensitive. And they might have that visual aura that people get before migraines, the floaters, the flashers, the curtain of light that people describe. And also another criteria is that it's not better accounted for by another vestibular or ICD diagnosis. Another central condition that can that can cause vertigo is going to be a seizure disorder. People who have severe migraine disorders will often have seizures, and vestibular provocation can bring about seizures, so that's something to be very aware of as you're working with these clients. Can we change seizures in rehab? No. Can we help people manage their symptoms, manage the kind of the fallout that they have with their vestibular symptoms? Yes. So what are some of the other central diagnoses that might cause vestibular problems? Parkinson's disease, multiple sclerosis, cerebellar dysfunction of any kind, or any other disease or disorder that impacts the vestibular, cerebellar, or cerebral pathways. I one time had the misfortune of having a client who had not been diagnosed with Parkinson's disease, and she came to me, and I'm like, man, that doesn't look right. That looks like a gait that is, it's a central gait. And of course, I'm not a physical therapist, but I've seen enough people walk that I know, a dysfunctional and central looking gait when I see it. So I referred her back to her physician, and she did indeed have Parkinson's disease, got placed on the Parkinson's medication, and fortunately, at least for during that time period, all her symptoms went away, so that was very helpful. A reminder here that sometimes what you're seeing is not central. It could be cardiac, it could be psychogenic. People who describe what sometimes sound like central dysfunction can be having psychogenic or other non-vestibular causes of vertigo. So what is our intervention for central vertigo? Just in general, we want to first of all get a diagnosis. We want to find out exactly what's going on with this person. I also once had a client who had a pituitary tumor, and he knew he had a tumor, but his symptoms kept progressing and progressing, and I finally sent him back to his physician, and they did another MRI, and indeed his tumor had grown, and unfortunately for him, it was a very poor outcome for him, and so we stopped therapy at that time. People tend to be slow to compensate with a central vestibular issue, so they're going to respond best if we're more gentle with them. So gentle habituation, putting them through some gentle motions that they can habituate to, using that brain plasticity to accommodate to that motion. Also dealing with their motion sensitivity, and also lots of compensatory strategies, wearing the sunglasses, dimming the lights, learning how to move and how to arrange their environment in a way that decreases their sensitivity is most helpful. In the literature, it is shown that people demonstrate improved balance after vestibular rehab, but the vertiginous symptoms can continue, especially in the case of vestibular migraine. Thank you very much, and we'll see you in the next episode.